knee joint. The next part is the there is a many bursa around the knee joint. The knowledge of bursa to know is where they are present is important because there is a one condition known as bursitis which causes pain in the knee joint and swelling of the knee joint. Swelling of the joint is usually due to bursitis and pain around the joint, not inside the joint. So bursitis is another problem of the knee joint in which knee joint is swollen and painful. So their location is important, where swelling can occur and where is the pain occur. One should know the bursae, their location, where they are present. Bursae are actually small bags filled with synovial membrane, have fluid. They are responsible for to avoid the friction rub between the two muscle tendons or between the tendon and capsule, so that doesn't undergo the surrounding tendons undergo any friction with the capsule of the joint. To avoid the friction rub, they are provided at various places where the bony points are there or the tendons are close to each other. So their friction rub is avoided by this bursae. So anteriorly, so numerous bursae are associated with the knee, and it is favorably asked in the SEQ also, name the bursae around the knee joint. What is their significance? Anteriorly, there is large subcutaneous pre-patellar bursa, which means in front of patella. What is present in front of patella is skin. So between the skin and bony patella, the name is given pre-patellar bursa, in front of patella, between the lower half of patella and the skin. So this is the one bursa. To avoid the friction up between the skin and the patella, a small deep infrapatellar bursa between the tibia and patellar ligament. The ligamentum patelli that pass to the tibial tuberosity, and the area part of the tibia above that and behind the uh, patellar ligament, there is a bursa. To avoid the friction up between this patellar ligament, ligamentum patelli, and the upper part of the tibia bone. Third bursa is subcutaneous infrapatellar bursa between the distal end of the tibial tuberosity and skin. So to avoid the friction rub of the ligamentum patelli with the tuberosity, this is the infrapatellar bursa. A large, next number 4 is the large suprapatellar bursa, which is superior extension of the knee joint cavity. Posterolaterally, there are bursa between the lateral head of gastrocnemius and joint capsule. There are two heads of the gastrocnemius attached to the femur. Between the lateral head and capsule is a bursa is present. Fibular collateral ligament and tendon biceps femoris. Between the fibular collateral ligament and the biceps tendon. Then the fibular collateral ligament and tendon of popliteus, and the tendon of popliteus and lateral femoral condyle. So these are the various places of other bursae between the lateral head of gastrocnemius and joint capsule, between the fibular collateral ligament and biceps femoris tendon, fibular collateral ligament, tendon of popliteus, and then is the tendon of popliteus and lateral femoral condyle. Medially arrangement is complex bursa between the medial head of gastrocnemius and fibrous capsule is prolonged. Bursa between the tendon of semimembranosus and medial tibial condyle. These all muscles are around the knee joint. So their tendons underneath have bursa, like semimembranosus, popliteus, and the other muscles. The the one bursa is located between the tibial collateral ligament and tendon of sartorius, gracilis, semitendinosus. These three cross the knee joint. In between them and the tibial collateral ligament, there is a bursa present. Inflammation of the subcutaneous prepatellar bursa and infrapatellar bursa are referred to housemaid's knee, or another name is given clergyman's knee. It occurs in those which undergo friction rub or are working on kneeling on the floor, just washing the floor or with the cloth and kneeling on the. So repeated friction rub lead to the inflammation of the subcutaneous prepatellar bursa, which is between the skin and the patella, and infrapatellar bursa between the ligamentum, uh, that is the ligamentum patelli, and the skin, that is swollen. Knee becomes swollen and painful. So with reference to the, because it mostly occur in housemaid, so name is given housemaid's knee. The movements of the knee joint next is the movement, that is the knee joint under the work on the one axis only, which is the transverse axis. And transverse axis passes through the center of the two tibial condyle from lateral side of the center of the two lateral condyles, tibial condyles, through the intercondylar eminence. It is not oblique, it is straight passing through the intercondylar eminence. On this, so any joint which has work on one axis will have two principal movements. Like in knee, there is one single axis which is the transverse axis crossing through the tibial condyle, just above the tibial condyle. Two movements occur, flexion and extension. Next is the slight degree of medial rotation and lateral rotation. This occurs when the knee is flexed. When knee is flexed, it can undergo, tibia can rotate medially and slight degree of lateral rotation. These are not principal movement. These are the conjunct rotation associated with those movement associated with principal movement, which are flexion extension. Name is given conjunct rotation. So there are two principal movement of the knee, flexion and extension. There is a differential motion in the medial and lateral tibiofemoral compartments. While describing the bony surfaces of the tibia and lower end of the femur, but it was said that the medial condyle AP diameter is more as compared to lateral condyle. So medial condyle is bigger than the lateral condyle. So laterally there is a considerable displacement of the femur on tibia with rolling as well as sliding at the joint surface. So when there is a, say from flexion to extension, femur is moving. If we move on in the same way, it will come in front of the tibia. So to avoid its movement to come in front of tibia, it undergo backward gliding and forward rolling. it roll forward, lower end of femur, and also glide backward, so that when full extension, in which the long axis of the femur, long axis of tibia in one line, making an angle of 180 degree anteriorly as well as posteriorly, then is the that is the full extension. And this is only achieved by the if the lower end of femur glide backward and roll forward in order to be accommodate on the tibial condyle. In contrast, medially for most of the flexion, there is minimum relative motion of the femur and tibia. Menisci move with femoral condyles. Axial rotation have smaller range than arc of flexion and extension. These rotations are conjunct. Rotation conjunct है. Associated with any movement associated with principal movement is conjunct rotation. Range of extension is 5 to 10 degree beyond the straight position. The femur can move maximum 10 degree forward than the normal alignment of the axis of the femur and tibia. It can move slightly forward by 10 degree. Otherwise it is 180 anteriorly and posteriorly. Active flexion is approximately 120 degree when the hip is extended and 140 degree when it is flexed. So when hip is extended, the movement on the knee joint flexion is 120 degree. When hip is flexed, then it is 140 degree, and 160 degree when person is on squatting position, that is on the ground, sitting on the foot on the ground, squatting position, when added by the passive movement. Conjunct rotation, which is associated with extension, is that is the medial rotation, internal rotation. Medial rotation which occur in extension is only 20 degree. Conjunct medial rotation of femur on tibia in late stages of extension is part of the locking mechanism. So the so-called screw home movement. Full extension result in close pack position with minimal spiralization and tightening of the ligament. Now what happens is the lateral femoral articular surface, I told you that is smaller. Lateral condyles of the femur and tibia are smaller, or the articular surface is smaller as compared to the medial. Consequently, lateral femoral condyles approach or fit with each other or full congruence with the post surface when some 30 degree before full extension, which means for the extension is actually start from flexion. The flex knee fully flex when it undergo extension. So when extension is 150 degree has been achieved, 150, that is 30 degree, normal extension is 180 anteriorly and posteriorly angle, that is straight line femur and tibia. The when from flexion we are doing the extension and 150 degree is achieved, that is 180 minus 150, 30 degree. 30 degree is left extension well before the medial condyle. So when 30 degree extension is left, the lateral condyles of the femur and tibia that come in congruent are fit together. Lateral femoral condyle approach full congruence with the post surface some 30 degree before full extension, which means the lateral condyle they fit together before completing the 180 degree or at 150 degree. This lateral condyle due to the small anteroposterior diameter or smaller condyle they fit together. Now when they fit together, knee joint is a bicondylar joint in which there is one condition that two condyle move simultaneously. Bicondylar joint are those which have two condyle, two concavities enclosed in single capsule, and they move together simultaneously. There are three things in the bicondylar joint: two condyle, two concavities that fit together, enclosed in single capsule in case of knee joint, and they move simultaneously. Simultaneous movement is only possible if the two condyle belong to same bone, not separate bone. So if one condyle become fit, say a lateral condyle which is smaller IP diameter of both condyle tibia and femur, if they fit at 150 degree and 30 degree extension is yet to be left, then it will not allow the medial condyle to move further or to glide backward or roll forward. Now movement will be stuck off. No further movement is possible beyond 150 degree, or when only 30 degree extension is left. So at that time anterior cruciate ligament become taut at that time, and that also does not permit the backward gliding of the femur. Anterior cruciate prevent the backward gliding of the femur or forward gliding of the tibia. This is its role. If foot is off the ground or foot is on the ground. If it is on the ground, it does not permit the femur to move forward, that is the move backward, or tibia to move forward. That is prevented by this. So 30 degree पे there is no further backward gliding of the femur. Medial condyle, lateral condyle fit, lateral medial condyle will not fit. Now how to achieve the 180 degree extension? The best way is the anterior cruciate ligament act as an axis, central axis, around which femur rotate by 20 degree, which is the conjunct rotation, medially. It is the only possible that medial condyle to fit with each other. Medial rotation of the femur is essential so that it can fit also, and we can achieve 180 degree. So last 30 degree extension when left, femur undergo medial rotation, which is conjunct medial rotation around the axis of anterior cruciate, taut anterior cruciate, and these two condyles they fit together and 180 degree extension is achieved. Simple extension cannot continue, but the medial rotation of femur occurs on a vertical axis through his head and medial condyle. The medial femoral condyle moves very little in sagittal plane. Rotation and extension follow simultaneously, smoothly, until final close packing of both condyle is accomplished. So two condyle now fit together. The lateral condyle fit together when 150 degree achieved, and the medial condyle fit together when 180 is achieved. In last 30 degree, what we said, the extension is completed by not by backward gliding and forward rolling, but rather by conjunct rotation. When rotation before at 130 degree, surrounding tendons, ligaments, the muscle ligaments and surrounding tendon and fibers of the capsule, they are all in normal natural position. And when medially medial rotation occur in the femur, they all the ligaments surrounding tibial collateral, fibular collateral, and the oblique popliteal ligament and the capsule fibers, they undergo spiralization while due to medial rotation. By this medial rotation, they undergo spiralization. The surrounding tendons of semimembranosus, semitendinosus, biceps, and the gracilis and gastrocnemius muscles, they also undergo bit spiralization. We stimulate these tendons and muscle contract strongly and bind the medial condyle, femoral condyle with the tibial condyle. What the term used is the they increase the intra-articular compression by this. This compression is so strong that the ligamentum patelli or the tendon of the quadriceps become relaxed rather than to be tight in full extension. By this spiralization and tightening of the surrounding ligament and muscles, name is given the screw home position or the close pack position of the knee joint. So close pack position phenomena occur in last 30 degree of extension due to medial rotation of the femur. So at the beginning of flexion from full extension with the foot fixed, the femoral, the lateral femoral condyle occurs, rotation occurs, which unlock the joint. Reverse occur. In that case, it is medial rotation. In locking, in unlocking, lateral rotation occur. And popliteus muscle is performing this function, give the lateral rotation. Joint surface and many ligaments they are involved. Contraction of the popliteus is important. It pulls down the backwards on the lateral femoral condyles. In knee extension, parts of the cruciate ligaments, tibial and fibular collateral ligament, posterior capsule region, oblique popliteal ligament, skin and fascia are all taut, become all taut. The name is given close back position, a screw home position of the knee joint. This phenomenon is important to lock the knee joint, that by spiralization, and one is stable on the knee joint, which is a highly mobile joint. Active extension, active tension exists in the posterior thigh muscle, gastrocnemius, anterior part of the medial meniscus is compressed between the femoral and tibial condyle. During extension, patellar ligament is tightened by quadriceps femoris, but it is relaxed in erect attitude, which I told you, because the intra-articular compression is more by the other muscles as compared to ligamentum patelli, so it becomes relaxed. When the knee flexes, the fibular collateral ligament, posterior part of tibial collateral ligament relax, but cruciate ligament, anterior part of the tibial collateral ligaments. Here it has been shown that normal extension is 180 degree posteriorly, 180 degree anteriorly. This is our goal. This is the flex knee, and from here we start the extension. If we continue like this extension, femur will move forward to the tibia. So to avoid that, it undergo backward gliding, number one, and number two, forward rolling in this way. Condyle of femur roll forward and it glide backward so that it could fit on the tibia. And this is the internal phenomena which is going on. Now the when 30 degree extension is left, that we have achieved 150 degree, and in front is still 210 instead of 180. Then the lateral condyle fit together. This is the picture of the lateral condyle, which AP diameter is less as compared to the medial condyle. because their diameter is small. So at 150-degree lateral condyle they fit together, and medial condyle fit by medial rotation. When 150 degree is there, extension is achieved. At that time, these ligaments, muscles, tibial collateral, fibular collateral, they are straight. But when conjunct rotation occurs, they all become oblique like this, spiralize, and tighten the femoral condyle with the tibial. Transverse axis, which is taken from center of this lateral side of the lateral tibial condyle to the lateral side of medial tibial condyle, traversing through the, not above, rather through it, intercondylar eminence, because axis is always straight, never oblique or up and down. So this is the axis of the knee joint on which two movements occur on flexion and extension. Knee joint injuries are common because knee is mobile weight bearing joint. The most common injury is ligament sprain. It occurs when foot is on the ground and force is applied against the knee. Tibial and fibular collateral ligament are tightly stretched when leg is extended. Tibial collateral ligament is attached to the medial meniscus, so causing the tear of the medial meniscus. Its injury is caused by a blow to the lateral side of extended knee. From lateral side tibia or femur, if it is hit, it will also obviously damage the tibial collateral medial ligaments, or excessive lateral twisting of flex knee. The flex knee, if the leg is twisted laterally, or tibia is foot and leg that is twisted laterally, that causes the tibial collateral ligament injury. Anterior cruciate ligament injury is common when this injury causes the free tibia to slide anteriorly. When knee is flexed and tibia is free, if it is pushed forward, because it prevents the anterior cruciate forward gliding of the tibia, so that is injured. Anterior gliding of tibia is prevented by anterior cruciate ligament, and posterior sliding is prevented by posterior cruciate ligament. So force of injury opposite to it causes tear of these ligaments. Meniscal tear usually involve the medial meniscus. Pain on the medial rotation of the tibia on femur indicate injury to the medial meniscus. Bursitis in the knee region. Prepatellar bursitis is caused by an excessive repeated friction between the skin and patella. For example, jobs associated with healing. Inflammation is chronic. The bursa becomes distended with fluid, form a swelling anterior to the knee. Subcutaneous infrapatellar bursitis occur by excessive friction between the skin and tibial tuberosity. This condition occurs in housemaid knee or clergyman's knee. Those working in the house, ladies, they get the friction rub. Nerve supply of the knee joint, femoral nerve, tibial nerve passing around the joint, which means femoral nerve passes around the joint, and tibial and common peroneal and saphenous nerve. These nerve passes around the knee joint. Blood vessels form the anastomosis around the knee joint. Genicular branch of the femoral artery, popliteal artery, anterior posterior recurrent branches are anterior tibial artery.